Okay. All right. So hi, everybody. For those of you who don't know me, I'm Mike Hoefer. I'm the medical director of the Opiate Treatment Program here at the San Francisco VA. And I also am the program director of the Addiction Psychiatry Fellowship. And today we're going to be talking about opioid use disorder, but primarily the goal of this topic is pharmacologic treatment selection. So which patients gets which meds and why and how we think about that. And I have a certain perspective on this because when I did my training in addiction psychiatry, it was during a time where all three meds were already available. And throughout my training and also at my clinic, which I actually didn't realize at the time, but now I do, it's actually very rare in America to have a clinic that provides all three meds to these patients, where they can come in and get, decide what they want, or we decide on it together and they can access it. In a lot of places, it's kind of like, oh, we do methadone. If you don't like methadone, you got to find somebody else. And we may give you a warm handoff, but sometimes it's kind of you're on your own. And so that's something that's been really gratifying at working at the VA, being able to provide all these meds. And it's also given me a fair amount of experience in all three meds and also transitioning people between different meds, which I'll be talking about today. We're going to start with some cases just to get everybody involved. So the first case is a 21-year-old male with a 6-month history of prescription opioid use disorder, alcohol use disorder, has no chronic pain issues, works as an airline pilot, although I think he's too young to do that, so maybe like a city bus driver or something like that. What medication would you might consider first for this type of patient for opioid use disorder? And just so we're all on the same page, the medications that are FDA approved for opioid use disorder are methadone, buprenorphine, and extended release naltrexone.
What are his goals?
So you could ask, like, are your goals harm reduction or abstinence, right? And so I think, for this one, he wants to stop using opiates, but he wants to, drink controlled.
Oh,
yeah, sir.
If they're thinking they're going to have to operate a machinery or something like that where they may be tested, then maybe Naltrexone or Naltrexone or something.
Excellent. Yeah. So there are people that are in safety sensitive positions, and they have limitations legally on what meds they can be on sometimes, but also if you function in a way that if you have some impairment that it could cause harm to others, that is one reason some people sometimes think about Naltrexone for opioid use disorder. Any other ideas why this might be a good case we might think about naltrexone for?
2 for 1.
No. Alcohol use, yes.
No pain.
Yeah, no chronic pain issues. And then there's also this idea that's not totally evidence-based from the research, but it is in practice, is that there's sometimes people, if they're younger, if they haven't really had an opioid use disorder for a long period of time, if we're thinking about putting them on something about methadone or buprenorphine, might be the rest of their lives. There is some thought about, hey, maybe we will first try something like naltrexone and see if we can stabilize them that way. And that does happen in clinical practice. Excellent. Okay. So the second case is the first case was what we might think about as a naltrexone case. The second case here is a 33-year-old female with a history of opioid use disorder, who's employed, lives in Tracy, which is in the Central Valley, over an hour and a half from here, has had multiple recent mixed drug overdoses requiring naloxone, has a congenital long QT syndrome, has hepatitis C virus with hepatic dysfunction, has lots of things going on. So what medication might you consider first for her, and why? Buprenorphine. Okay. And what are the reasons for that? Yeah, and exactly. It has, the research shows a small effect on QT, but thought to be not a clinically significant effect in the way that methadone does. Yeah. Other reasons?
She's in a rural area, so I personally don't know if there's a methadone clinic in or near Tracy.
Excellent. Yeah. So distance, logistical things, getting to a clinic, and what we find really is if somebody lives more than 20 to 25 minutes away, it's very rare that they make it through methadone treatment where they have to start 7 or 6 days a week for the first 3 months. What else?
And also she has a history of overdosing, so avoiding things like methadone, buprenorphine is less of a risk.
Sure. So methadone has a lower risk for overdose and lethality compared to methadone in mixed drug overdoses.
So liver dysfunction.
Yeah, exactly. So buprenorphine has a pretty relatively simple metabolism, doesn't tend to accumulate or cause issues in the way that methadone might, and naltrexone does have a rare but potential for causing hepatotoxicity. So those are all reasons why we might think about buprenorphine for this patient. Okay. Here's case number 3 is a 55-year-old male with a long history of injection heroin use, history of aggression, severe chronic pain, hepatic function is normal, is unemployed, homeless, and has a long history of diverting controlled substances as far as legal charges and things in the clinical record. Which medication might you consider for this patient? There's only one left. Yeah, okay. And what kind of things might methadone, and the structure that we actually put around methadone, at least in the US when we provide it, might be helpful?
So you provide methadone at a clinic, go there daily, and so it would be very difficult for him to divert it because they watch you take it. I think you have to be on good behavior for a year or more before they'll let you take methadone.
Gotcha. So that's all, yeah, pretty much essentially correct. Really, you can start getting take-homes of methadone after about 90 days, but it's one, and it takes a while to build up.
That's like Sunday, right?
It depends. If your clinic is closed Sundays, you can get that at the beginning, but if not, then it's Sunday, then it's Saturday. And then it really takes 1.5 years to 2 years until you, like, doing everything perfectly to get month take-homes, basically. Yeah. So that's one thing. Anything else that might make you think methadone might be helpful for this patient?
It's chronic pain.
Chronic pain, sure. Yeah. Other things that people maybe less don't think about as much. So methadone in some patients really dramatically blocks their testosterone. And that actually can have effects that we don't like depression, sexual dysfunction, osteopenia, but it can also help with aggression. And so I actually have had patients, anecdotally, who have been testosterone depleted. I start them on testosterone again. They start getting into fights with people and get aggressive. And then they've actually, 2 of them have come to me and said, take me off of testosterone. I do much better when I'm not on it. And there's actually some interesting data on methadone and criminality and aggression. And so that's one thing, not that that's like the first line treatment, but it's something that is an effect of this medication. Yes, and then I think also just, homeless, thinking about managing take-homes as a homeless, thinking about being robbed for take-homes can be difficult, and then providing structure is helpful. Okay, so those are 3 cases. Here's kind of more of a theoretical case. It's not one that you actually see in practice very often, but I think it's a useful thought experiment for us to have. This is a 30-something-year-old patient with opioid use disorder, no previous history of treatment, is interested in pharmacologic treatment, but says they have no preference, and basically asks you, what would you take if you were in my position, doctor? And I love to ask OTP providers this, and they pretty much all tell me the same answer. So I'd be interested to hear what you guys say.
I'm thinking naltrexone.
Okay, yeah. And why naltrexone?
I haven't had treatment. I'm 30 years old. I might not need to be on something for the rest of my life.
That's a
You
great
mentioned
point.
earlier, if I don't have to take an opioid, I can do well. Or non-opioid, I prefer that.
Okay, great.
Isn't it also true that professionals tend to do better on naltrexone specifically for opioid use disorder than physicians?
Yeah, so the data on medical professionals or other professionals, if they're in mandated treatment and they're going to lose their license if they don't comply, and they're on naltrexone, some of them have recovery rates as high as 85-90% over 5 years, which is unmatched in really any other treatment population. Yeah. Yeah, so I think naltrexone is a reasonable offer. But would anybody want to be on anything not like naltrexone?
I would say Bup.
Okay, yeah. Why Bup?
Well, if you want to start naltrexone, you have to be off of opioids for like many days, and that can be really challenging, and potentially like unattainable for a lot of people, and so that could potentially be really discouraging for someone. And I think, you know, buprenorphine, like, you can get take-homes right away, and it's really effective, it's really safe, so it just seems like a good middle ground for me.
Sure, absolutely. Would anybody in here want to be on methadone as their first choice? No? Okay. So I would agree. I would think, when I asked this question myself, I would say Bup. And the only reason is induction, retention, which we'll talk about in treatment. And, you know, I have back pain. It might be nice to have some help with that. I get sad. Sometimes it'd be nice to probably have some antidepressant effects from it. I think that's probably what I would try. But I think there's a good answer for both. But this will loop back in later, but essentially more and more guidelines up to date. Certain addiction societies are starting to look at buprenorphine as really being the first line treatment for opioid use disorder due to availability, due to flexibility in dosing, and due to safety, things like that. Yeah. Yeah.
Just because you mentioned this a couple times, like what percentage of people are able to come off naltrexone versus the others? This week, saying that you get to come off naltrexone.
Come off of it, like
Just
plan, taper, to discontinue it. We don't have any great data on that. We just have data on retention, like people who drop out is the data we have. And, you know, jumping the gun, naltrexone has the worst retention of anything. Yeah.
Just a general comment towards the question of, you know, patient asking you, what would you do? There's some interesting data in family planning that if the patient knows what contraceptive the physician would prefer, they actually have a decreased rate of adherence to that medication. So I'm wondering if there's any similar data for this type of thing. The idea being, you know, somebody asks you, what is it that you would choose, and knowing that you're a very different person than the patient in front of you, and thinking about how we counsel people based on their experience versus ours.
Yeah. No, I'm not aware of any data on opioid use disorder for that. And I think this is not necessarily to like talk about how you cancel a patient, but I think this is more of a way of trying to think about, is there a first line treatment for this disorder? How do we kind of think about that, you know? This is a way of getting at that question,
In a
you
more
know?
personal way.
Yeah, exactly. Yeah. Okay. So another kind of thought experiment is same exact patient, but they come in and say, I do have a preference. I want, let's say in this case, I want methadone. And this is one I hear most often. I want methadone because my brother or my cousin or somebody I know took it. It worked for them. I want what works for them. I think it'll work for me. How would you kind of respond to this? And what do you think about that?
I love the positive mental energy. Like, this is something that they really want, and they believe in it. I think there's a lot to be said about, you know, doing something that the patient like believes in, even if it doesn't work.
They're
Yeah.
asking for it, and it shows that they're like really motivated for it to work. Maybe that might go along, might actually have them be successful.
Yeah.
I agree with those things. I just want to know what it means by like worked.
Yeah.
Like, is it that they went to nil use, or that they were able to control their use, and sort of how is that in line with the patient's goals?
Yeah. Yeah, I think that's great. And I totally agree with what you guys said. I think this is something that commonly happens. And I think the way I think about this is we don't have, for this medication, we don't have any research studies that really show predictors of like based upon whatever you're going to do better on this. Just like Steve talked about in all of psychiatry, really, right? So that's a problem. So the other thing, and we don't have, like I think about like in medicine, we have a urine culture that says this is, your bug is sensitive to this and it's resistant to that. And we don't have that, right? So without that, I think there should, in my factors in making the treatment decision, patient preference is usually like the number one factor, really. Unless there's some real contraindication that comes up that we'll talk about later. But that's often one of the main factors that you should think of. And I think there is something about somebody, them coming in and being interested in it. Not only will you have a better placebo response or on top of the med response, but I think you'll also have improved adherence, and it'll also help with your alliance and the transference to the medication, all those things. Okay. All right, so this is the outline of what we'll be talking about going forward. I think everybody in this room has probably heard 100 lectures on the opiate epidemic. So we're not going to do that. We're just going to talk about what's happening in 2019. We're going to talk about the meds, and then we're going to talk a little bit more about how we do treatment selection. So this is opioid use disorder. I'm not going to read all these, but just to say we're interested in people who not are using opiates recreationally necessarily, but people who are using it in a way that's really harming their lives, and they want help with that. This is a study that's in like every opiate lecture ever. It's a kind of a confusing graph, but focus on the percentages on the far right. This is really the best follow-up we've ever had. 30-some years, 600 patients in LA who are heroin addicts, largely during a time where people did not get treatment for opiate addiction. So a natural history of opiate addiction for the most part. There's a little bit of methadone maintenance that comes in, but most of these people didn't get treatment. And what you see is at the end of this period, 50% of people are dead. 22% are abstinent, and the death rates are not just overdose, but it's like suicidalities, motor vehicle accidents, all sorts of other medical issues. Some are incarcerated, many are continuing to use. And the death rates are about 10 times the age-matched control population. So this is just something to look at, that opioid use disorder is a very serious condition, and that's why we're interested in wanting to treat it. This is another slide I always like to show. It's getting a little dated, but the most recent data is not different than this. This is a breakdown of opioid consumption by country in the world, and so each bar is a different country in the world. And this is for oxycodone, but it holds for lots of other opiates as well. Anybody want to guess what the bar on the far left is? USA, yes. Okay. Anybody want to guess what the second bar is? Canada, exactly. Great. So, yeah, so that's it. So we still consume way more opiates than any country on earth. So some good news that's somewhat recent is, or could be considered good news, and I think it is. So opiate prescribing has gone down in the last few years. This is data from 2013 to 17. Anywhere from 25 to 40% across different states decrease in prescription opiates, okay. But even with that decrease, we're still about 2.5 to 3 times above other industrialized countries, including Europe and things like that. So it's getting lower, but still higher than anybody else. And just for now, we're starting to see a signal of when decreasing that supply, are we seeing any difference in people developing addiction, people getting treatment. So this is information from the National Survey of Drug Use and Health, 2017. And they've just started to see some uptick in decrease in pain relief, misuse, use disorder, and heroin initiates. And so we know that people who initiate heroin use, 30 or 40 years ago was usually people who were using illicit substances, and it was kind of an end-stage addiction process. More recently, it's 80 to 90% of people it's starting with prescription opiates and then going to heroin. And so we're seeing some decrease in that now. And we are seeing an uptake in people engaging in treatment for opioid use disorder and heroin use disorder. So supply is going down, addiction slightly going down, treatment's going up, but we also are seeing this, right? So overdoses are not going down. They're actually going way up. And this is actually very different than like other countries. I didn't put it, but there's another graph you can see of like France in the 1990s when they were having a heroin and HIV epidemic, and they put out methadone and buprenorphine across the national health system in primary care in like Monday we're doing this, and saw a dramatic decrease in overdoses. And we have not seen that. And so people speculate why that is. So number of reasons. One is increasing synthetic opioids, fentanyl and fentanyl analogs. 2 is nationalized healthcare, where you can really make this available in a way that nobody had to have a DEX waiver, nobody had to go to an opiate treatment program, nobody had to do all these things. But this is where we are right now. And I'm sure you guys have all heard about fentanyl at this point. But things that come up clinically that can be difficult. So fentanyl's interesting. It has a very short half-life, but it also has a lot of lipophilicity. So even though the half-life in your blood it gets chewed up pretty fast, it can stay in your tissues and kind of leak out. So for some people, the short half-life means more injections per day, which can mean more risk for overdoses, infectious disease spread, and abscesses. but also it leaching out into your system over time can also make buprenorphine inductions more difficult. So sometimes there's more precipitated withdrawal and things like that. So it's kind of tricky with fentanyl. The other issue is just testing for it. It's a synthetic opioid, so you need specialty testing for it. A lot of people don't have that. So often people don't know if their patients are taking it, and often patients don't know because it's mixed in various drug supplies, not only heroin, but crack and meth and sort of counterfeit pills and things like that. And because of the affinity and affinity mostly of this medication, we are finding that people in our clinics, in order to get a blocking dose that holds them, we are having to give them higher and higher doses of methadone or buprenorphine. And sometimes we're unable to fully block it. And higher doses can expose people to more risks for side effects and things like that. This is something we've been using in our clinic. This is a company out of Canada. I don't have any financial connections with them, but we like their strips. They're like $1 each. We test them on patients who are using heroin to see if they have fentanyl in their urine, to see if that's going to make our bup inductions more difficult. Also, we give them to them so they can test their own supply. I know there are people at Harm Reduction Coalition and through DPH that have been using test strips and have been really concerned about too many false positives with them. We haven't really found that. I'm not sure if they're using the exact same one, the BTNX, but we haven't found a lot of issues with false positives in our use, but I know that's been something that's circulating. We found them helpful in our clinic. Okay. So we're going to be talking about meds today, but just wanted to put this in the context of all the other things that are going on to try to decrease opiate deaths. And I'm not going to read all these, but those are other initiatives. This is a slide that was put together by our fellow last year, Takeo Toyoshima, which I think is really a cool slide. So I stole it from him and put it in here, and he gave me credit to do so. So anyway, let me explain this. So this is a little bit about overdose and access. So the picture on the left is rates of overdose in our state of California. And what you see is at the north and northeast part of the state, we have the highest overdose rates by far. So like Humboldt, Ukiah, those places. The thing on the right is where are the opiate treatment programs, And this could be a proxy, this could be opiate treatment programs, but I think this is even better proxy for like where are the psychiatrists and the primary care doctors and the nurse practitioners, right? We're all in San Francisco and LA and places that we want to live, right? And where are the patients who are dying, Yeah. So that's a real issue and something that's happening across the nation. And so how do we address that? There's lots of different ideas. But one hope is, and one thing we're doing, at least in the VA, is really trying to scale up our telehealth services and running buprenorphine groups and outreach for Vivitrol and other things in our C-Box and trying to leverage whatever we can to do that. Because I think that's really one of the hopes for how do we going to reach rural people with substance use disorders. And so that's also something we're trying to build a lot more into our training program. Okay. So these are the meds. For all the meds, what are we trying to do pharmacologically? So 3 things really what we're looking at. So preventing or relieving withdrawal from opioids, especially for bup and methadone, minimizing cravings to try to decrease relapse, and achieving a blocking dose. So can somebody tell me what a blocking dose is? I know one of my fellows can.
I think that's where you get enough, or you get to like the right dose that like a high enough of a dose that if they were to take exogenous opioids or whatever, that it like prevents, I don't know if it's the getting high part? Yeah.
Yeah, so you're taking a high enough dose of these medications that if somebody uses heroin or whatever, it's not euphoric, and behaviorally it's kind of, that thought is, oh, that was a waste of time. I'm not going to do that again, hopefully. So these are the things we're trying to do. The things that we are counseling patients about is we're not adjusting these medications to try to help you with anxiety or depression really, or you got into an argument with somebody today and you want something else to deal with that. I think sometimes with these medications it can be kind of used as a catch-all to deal with everything that you don't like is going on in your life. And I think we really try to work on like what we're trying to use these medications for, and then also offering whatever we can to help with things like interpersonal relationships, anxiety, depression, other things like that, because we have effective treatments for those.
I think it's important that just to like notice that like pain's not up there, and that's something that comes up a lot. You can get into a really big push.
Sure. Yeah. So there can be a big push for a lot of ways to be using these for pain, and they do have secondary benefits on pain, and we're open about that. And we try to help people, but also to not continuing to go up just for pain. And then also there's also a big thing where it can be like, I'm only on these medications for pain. I don't have an addiction, and there can be motivational discussions about that are you have to have. Yeah. Okay. So those are the pharmacologic effects. These are also just an overview of the public health effects. So because, not really now, but I think 20, 30 years ago, these treatments, especially methadone, was more controversial. So it actually is probably one of the most overstudied medical interventions in the world because it was so controversial, and repeatedly moderate to large effect sizes in all of these areas. So it's really helpful preventing overdose, infectious disease spread, criminality, and improving functional outcomes. Okay, so methadone, how does it work pharmacologically? It's a mu opioid agonist. Can somebody tell me what the 3 opiate receptors are and what do they do?
You have the delta.
Okay, great.
And I'll hand off the rest of the answer.
All right, pass it. Tag out.
So mu is going to be related to
Hey, bye.
feelings, euphoria.
Mm-hmm. Yeah.
Take another one.
And is mu also pain?
Yeah.
Yeah.
So unfortunately, mu is pain and euphoria. And there's lots of work being done pharmacologically to try to activate the receptor, because there are different secondary messenger cascades. So can you activate it in some way that you help with pain without getting addiction? And we haven't been able to do that yet. But that's a big area of pharmacological research. Yeah. Okay.
Does kappa also have some pain modulation effects?
So they all have some pain, but mu is primary. Kappa is more, kappa agonists can be like kind of dysphoric. And kappa antagonism is a part of buprenorphine, which can actually have a mood elevating property. The other thing that's interesting about kappa is, does anybody know what salvia is in this room? Yeah. So salvia is actually just a kappa opiate receptor agonist. And so, and it's kind of a brief, very intense hallucinogen. Yeah, that's available legally. Yeah, I think still. Yeah. Okay, Delta is kind of a freebie. Nobody really knows much about Delta. So, Tramadol kind of works on it. There's not a lot there. So one other thing that's kind of unique about methadone is that it's an NMDA glutamate receptor antagonist, which a lot of other opiates are not, and that is speculated or theorized to give methadone some of its pain relieving properties, and especially the lower incidence of developing opioid-induced hyperalgesia. So can somebody tell me what that is?
Hyperalgesia, this is basically when an opioid user stops using and then everything hurts them. Right? Isn't that where they come in? Like even a simple blood draw is very, very painful.
I think that's mostly, so it's actually more thought of for people who are on opioids, and that there's somebody, it's hard to guess the estimate. I've seen estimates 15 to 20% of people on short-acting opiates will actually develop opioid-induced hyperalgesia, where you have increased pain response or sensitivity of pain pathways. Yeah. And then when you come off of opioids, that can also be present, but also you now have withdrawal as well, which also increases pain. Yeah. And methadone has basically a lower incidence of doing that. So methadone duration of action is about 24 to 36 hours. So the idea is, does anybody here know how often, if you're on heroin, you have to inject to not feel sick? A lot?
4 to 6 hours.
Yeah. So people mostly injecting 3 to 4 times a day, more if they have access. And that can be very much a full-time job, getting supplies, finding money, getting heroin, injecting, and then going in withdrawal. So Methadone is helpful because we can give it once a day, and then hopefully people can stabilize and focus on other things. But if you are giving it for analgesia, we do the analgesic efficacy is only about 6 to 8 hours, so it is often dosed BID or TID through pain clinics. There's been a lot of research on target doses, and historically doses have actually been too low. And so most people recommend a target dose for patients between 80 to 120 milligrams, although there's incredible variability in people's metabolism, not only with their liver, but also in their GI tract. There's genetic differences in P-glycoprotein transporters, which basically absorb methadone from the GI tract into the blood. And because of that, you can, and I've seen this, you can have people who are on 300 milligrams of methadone and 70 milligrams of methadone, and their serum plasma levels are the exact same. And so that's something that we should do education with other providers about, because people see doses and then you're too high, this is very dangerous, but it's actually the serum plasma levels that are most important, and it has to do with variability. Other things that people don't know about methadone, and actually all opioids have actually a mild antipsychotic effect. So it's not first-line treatment for schizophrenia, but for patients who have psychosis, it will actually stabilize it some. And methadone, people on methadone tend to feel medicated and also tend to report some anxiolytic benefits. So it's some things I think about in medication selection for people with co-occurring mental health issues. Okay, why is methadone served like that? Why do we have it in a liquid in a cup that's like fluorescent red?
Diversion. Okay. Or like encouraging people to be able to see that they're taking the whole amount in that moment.
Gotcha. So liquid observed helps with like cheeking. And so they take it, you give them a candy, they talk to you, things like that. Why is it radioactive red?
To make it more likely for kids to want to drink it.
For business recruitment, yeah, like jewels and things like that. Yeah. So it's like that because that is not only a flavor, the flavor's not so great on its own, but also that has additives and sugar in it. And if you try to inject that, it's painful, and it can also negatively affect your veins. Yeah. So it's a deterrent for injection. Okay. Side effects from methadone that we need to monitor. So we talked about prolonged QT earlier. People who have pulmonary issues like obstructive sleep apnea and COPD, it's not a contraindication, but it's something that can put them more at risk for respiratory issues with methadone, especially if they mix it with other drugs. Androgen blockade, we talked about the issues with that. Medication interactions with methadone are very real, and we've had people who who you really do have to adjust the doses. And the one that's really tricky is if somebody that we had here, somebody was put on rifampin for TB. We had to increase their dose by 30 to 40 milligrams. They stopped taking the rifampin, didn't tell anybody, and then they were oversedated and actually got Narcaned. And so, and it's fine now, but we have been really following up. So it's not only adjusting to go up, but if people, there has to be lots of education with nursing staff and the patient about if they stop these medications, often the dose has to go back down. And so something for you guys to just keep in mind. And then the bottom ones are the more common side effects.
What is AE?
Antiepileptics, maybe?
Antiepileptics, yeah, sure. Sorry for these are my acronyms. Okay, buprenorphine. So buprenorphine is a partial agonist at the mu-opioid receptor. So what is a partial agonist? What are we talking about? That versus a full agonist? And it kind of is related to the words below it, but not totally.
There's a ceiling effect.
Exactly. So a partial agonist is a medication that binds to a receptor, and there's a ceiling effect on its effects. So if there's 100% activity theoretically, that's what methadone or fentanyl or whatever can do to an opioid receptor. This medication will only, let's say, activate the receptor up to 50%, like if you think about like a dimmer switch on a light. And even if you push the dose to insane levels, you will not get above that. And that works for activity, for things like euphoria and pain, but kind of for pain, not as much. But it primarily works for respiratory suppression. So you can take insane amounts of Suboxone on its own and not shut down your breathing. And that's why it is more safe. It also has other pharmacologic properties that are important to know. So it has low intrinsic activity, which is kind of the same thing as partial agonism, actually, really. High affinity, so that's the rate at which it binds to receptors and outcompetes other opioids. So if in your synapse there's buprenorphine and methadone or something, or heroin or something else, the buprenorphine will outcompete those to bind to the receptor and prevent a lot of those other drugs from binding. And it also has a slow dissociation constant. So what that means is drugs bind to receptors, let go, bounce on and off, and this medication binds and lets go very slowly, giving less opportunity for other medications to get in there and activate those receptors. It's also an antagonist at kappa opioid receptors, which we talked about earlier, which is thought to maybe give it some of its mood elevating properties, and it's actually being studied as a treatment for treatment refractory depression for that. And in that, they actually mix it with a medication called samidorphan, which is a selective mu opioid receptor antagonist. So why put buprenorphine with a selective mu opioid receptor antagonist? I think I kind of just answered.
You're not going to have euphoria. Like, it's not going to be addicting.
Exactly. So you block actually the euphoria, and you actually can block the physiologic dependence on it. And you isolate the kappa receptor antagonism. And that's in phase 3. And the data, what I've heard is the data actually looks pretty good, but the FDA said no. And there's some concerns as they're running more studies. So, yeah.
That would be a quicker onset than, say, the 6 weeks for SSRIs.
Yes. Yeah. So more in the kind of when we're thinking about rapid acting antidepressants, ketamine, buprenorphine, ECT, things like that. Long half-life, even longer than methadone. Some people can dose this medication 3 days per week, and we do that in patients who are having difficulty coming to the clinic a lot, but they don't meet take-home requirements. So we just give them 32 milligrams Monday, Wednesday, Friday, and that actually works pretty well for some people. It's combined with naloxone in this country because when it first came out in Europe, mostly in France and other places, it was available just as a mono product, and there were not a majority, but there was a percentage of people that were injecting the medication. And in order to prevent that, they mixed it with naloxone to put it here. Does everybody understand how the naloxone works? You guys know this? Okay, I won't belabor that. But the issue is, you should know there are ways of injecting the combo product that you can, if you do the right amount and whatever, you can still inject it and get buzz off it. But very few people do that, and the data shows very clearly that less people are injecting buprenorphine in the U.S. compared to other countries where it's available only as a mono product. It has a simple metabolism, and this is the dose range, 2 to 32 milligrams. The data is, more and more data is coming out that the higher doses people are on, the better retention and the better effects on opiates. And so there's some people, practitioners who really try to keep people on low doses. We don't go above 8, we don't go above 12, we don't go above 16. More and more data is coming out that people do better at higher doses. In the same way that we saw with methadone 20 or 30 years ago, where people were being capped at 40 or 60 milligrams, and the doses have gone up over time and people have had better outcomes. So we talked about this in the cases earlier, but more people are recommending buprenorphine as the first-line treatment for opioid use disorder. To overdose on it's very hard. Really, I think 90% of the cases of people who've died on buprenorphine is injecting buprenorphine and taking large amounts of benzodiazepines concurrently. Otherwise, it's very hard to die. It has a relatively mild withdrawal syndrome overall, which means if you take 100 people and put them on methadone, 100 people on heroin, 100 people on buprenorphine, and they all go through withdrawal, as an average, the buprenorphine people will have a less severe withdrawal. But there are some people, which is probably genetic variability, who have a very difficult time coming off this medication. And it can be incredibly hard, especially at lower doses. So we don't try to minimize that, but we do talk in generalities. It is easier, and that's why a lot of detox protocols and other things, people move people from methadone or other things to bup first before finishing, because it is often easier to come off of. These are side effects. The ones on the left are things that you've seen that we saw in the RCTs. The ones on the right column are things that make buprenorphine a little bit different than methadone. Okay. And we're starting to see more and more use of different formulations of buprenorphine, so just things for you guys to be in mind. Transdermal buprenorphine has been around a long time for pain, but we're starting to develop, and more people are publishing and doing protocols with transdermal buprenorphine to help people actually get onto buprenorphine, mostly switching from methadone, which can be very difficult, but also sometimes switching from fentanyl more as those inductions get more difficult, or just incredibly high dose like MS-Contin and things like that. You can use transdermal buprenorphine as a bridge to try to get people onto buprenorphine. And then we've also been using in our clinic now for about 6 months Sublocade, which was once a month injections of buprenorphine for people that either have adherence issues or difficulty coming to the clinic. And what have we found so far? The people that have stayed on it really, really like it. The biggest complaint is that the injection actually burns a fair amount going in, and it forms like kind of a hard pellet in your abdomen. So we've started to pre-treat people with like lidocaine gel or even lidocaine injections. Because I have a friend in anesthesia just showed me how to do it. And that's been helpful. Yeah. So
Does it have to be in the abdomen, or can it be anywhere with?
That's what it says. I haven't heard of people doing it that's the directions, and I haven't seen people do it anywhere else. But yeah, but I'm not sure if people have. I'd be interested to hear if you hear of anybody put it anywhere else. Yeah. We've also had to. It takes a while to get to steady state on it. So the injections are 300 milligrams, 300 milligrams, 100 milligrams. Sometimes you have to give people sublingual during the first month or two till they get to a steady state, and that's totally fine and safe. And then the other thing, just buprenorphine in pain. Again, you got to do BID versus TID dosing, same as methadone. We used to stop people, or not we, people used to stop people's buprenorphine during procedures, but now overwhelmingly the recommendations are to continue it perioperatively and peri-procedurally. Not only does you can add short-acting opiates on top and have analgesic effects, but also at the tail end, people can come off those analgesics much easier. It's one of the few times in my practice I've ever had people like hand me Vicodin and hand me other things and be able to come off of it when they stayed on their buprenorphine. So that's good to know. And there's more and more guidelines coming out talking about buprenorphines, not only used in people with both opioid use disorder and pain, but also just pain in general. And we don't have time today, but these are really great references to look at for buprenorphine and pain in people with misuse or not misuse. And there's some, and I don't think the field's really there yet, but there's some discussion about, I think we agree that short-acting opiates for chronic non-cancer pain for most people is not helpful. People still get started on opioids, and if you are going to start them on something, I think there's an argument to be made that buprenorphine is actually a much safer medication than giving them oxycodone or something like that. So, but that's controversial for some other people. Okay, the final medication, extended release naltrexone, mu opiate receptor antagonist. So it means it binds to these receptors and doesn't activate them at all. It just blocks other things from getting on there. It's given intramuscularly into the gluteal muscle every 28 days. Right now, it's thought to be contraindicated in pregnancy, or it's been taught that way. There are more people actually doing research because the data is mostly in animals. And there are people who are looking into using it in humans, but it's a very controversial area. So right now, the recommendations clearly for pregnancy are methadone and buprenorphine. How does naltrexone help people not drink alcohol? Steve kind of touched on it last week, but I want to see if people remember and really understand that. Why would an opiate blocker help people not drink alcohol?
Is it because like endogenous opioids are involved in the reward pathways in our brain? Is that what you're getting at?
Yeah,
Okay.
kind of. Yeah. So I think, it's specifically you drink alcohol. It's a very, what we call dirty drug. It affects lots of neurotransmitters. One of it is it increases the release of beta endorphin and enkephalin. And when that binds to opiate receptors in your brain, that gives you a euphoric response. And so if you block that, you can bring down some of the euphoria from drinking, and people tend to not drink as much. And the main effect for naltrexone is decreasing heavy drinking days. So people drink, but they don't drink as much, and they don't have as bad outcomes. The other thing it does is when you have an alcohol use disorder and you walk by your favorite bar or see a beer commercial or whatever, that also triggers the release of beta endorphins and enkephalins in your brain. And if you have naltrexone on board, it prevents them from binding, and that decreases the strength of the triggering or the craving response that you have. Just want to make sure everybody understood that. One thing that's important about this medication is people have naltrexone in their muscle that you can't just cut out like an implant. So if they get into a car accident or some other type of trauma where they need pain relief, we do lots of education with them, the family, have them carry a wallet card so people will know they're on this. And then mostly people will either give them non-opioid based anesthesia or try to overcome the blockade with something like fentanyl. But doing that with an anesthesiologist is what usually happens. This is a plasma curve of the shot versus the tabs. And all I would say with this is that you have a smoother plasma curve with the shot, and a lot of side effects in pharmacology have to do with peak and trough responses. So by smoothing that out, people have less side effects on Vivitrol. And there's actually some people that cannot tolerate oral naltrexone but can tolerate the Vivitrol shot. And so we use that sometimes. Sometimes we don't give people oral ahead of time because we know that. And if they take it orally and can't tolerate it, then they say, well, I'm never taking that again. But they may actually have been able to tolerate the shot. So it's something to think about. So what are the big pros and cons of accidental release naltrexone? So the things that are kind of like potentially pros, it's not euphorogenic. You don't go into withdrawal if you don't take it. It has no street value. And there's no way you can overdose on it. So those things sound pretty positive. The cons, which are significant, is really only, my guess is about 5 to 10% of patients are even interested in taking this medication. And that is because it is very difficult to get onto it. You have to be opioid free for 7 to 10 days per the FDA. We'll talk about a protocol that's faster than that, but that's the recommendation. And even if you do get on it, in naturalistic studies where they do like retrospective case charts through, centers, people who've been put on it, at 6 months, there's only about 10% of people still on it. So it's difficult to get on it, and retention is actually difficult in naturalistic studies. But does anybody else know another intervention where only 10% of people are in the room after 6 months that we recommend all the time to everybody? AA or NA. It's a very similar retention rate to that, So the way I think about naltrexone is it's very few people are interested in it, and even people who stay on it, very few will stay on it. But people who do, in my experience, and there's some data to show this, the people who do stay on it and for whatever reason want it and are able to manage it actually can do very, very well. Same thing kind of like with AA. The people who self-select for that can make incredible changes in their lives in very short periods of time. So that's something about this medication. We have just the shot here now, but actually in other countries they have the implants, which can last up to 7 months. And there's actually reports being put in now for implants, or they're applying to do them in the U.S. But there's actually clinics in the Bay Area. Maybe you guys have seen patients. I've had patients who have implants, and they actually provide them. It's usually cash pay. I don't know how they do it. It's like off-label, imported from Australia. But there are people who are getting them here now. And I think the thought is that we will have implants in 5 years. And this is totally my opinion, but I'm actually a lot more excited about the implants than the shots. I think the data looks a little bit better for the implants, and it just lasts a lot longer. And if you have a really bad reaction, you can take an implant out. You can't do that with a shot in the muscle. Yeah.
What are the treatment retention rates for, compared to methadone or buprenorphine?
Well, okay, so I have that, but we'll do it now. It's variable, but methadone, best retention by far out of all of these. At the end of the year, 70% on average are still in treatment. But it's a range. Buprenorphine, 45 to 60% are still in treatment. Naltrexone, 10%. Naltrexone probably better. So those studies that I just gave you are actually like clinical research studies, so their retention is better. In clinical research studies, naltrexone is more like 30%, but in naturalistic studies it's 10%. Yeah.
And by retention, because you mentioned that naltrexone is like the one if somebody wants to come off of these drugs, they potentially might be able to, or most likely to succeed in getting off of treatment. So with the retention is 10% that's still getting medicated after 6 months, but do we know is there any data about the proportion that's not overdose rates or anything?
And that's not that I've seen, and that's the great question, because unlike coming off of methadone and buprenorphine, where you're going to be in withdrawal and going to have to figure that out, and most people figure that out by using opiates they can get their hands on, coming off of naltrexone, you don't have that. So that's like a really important question I haven't seen great data on. It's like when people stop methadone and buprenorphine, especially drop out, pretty much the expectation and the way we analyze the data in studies is they relapse, for most of them. It may be slightly different with extended release naltrexone, and we don't have that answer, but it's a great question. Yeah.
And how long are you recommending to patients to stay on the naltrexone?
So I recommend everybody, I think for all the medications, for a year, essentially. And there's no great data for that, but it's essentially, it takes a while for your brain to stabilize after coming off of substance use. There's some data about stress pathways and sleep and other things starting to come online after a year or two. There's also, you need time to build. This medication, what I say to him is this medication is a big support for you, and if you want to come off of that, we can work on that, but we also have to give you time to develop other supports in your life, because when you take this support away, what else is going to be there for you? And it helps, it's enough time that people are willing to go onto it, but it also, because some people come in and, by the time you give them their first dose, they're like, I want to be off of this, And so it stretches that out, but it also doesn't get people into this thing of, I'm going to have to be on this for the rest of my life, But if you do, it's totally fine. But I say do it for at least a year, and then we'll talk about it. If you want to come off, I don't ever try to push people off these medications because the relapse rates are so high, but if you want to come off, I'll work with you. We'll see how it goes, but we have an agreement that if it's not going very well, you're going to let me know, and we're going to figure it out together, basically.
I've heard of this very non-FDA approved use of naltrexone, which is my friend that works in this very foo-foo rehab center in New York, where basically one of their protocols, particularly for people who are using fentanyl, because there's this thought that even if fentanyl is short acting from how we know it, it lasts in the body for longer, as you were mentioning. That there's this microdosing of naltrexone. Have you heard about this?
Yeah.
Do you know what this is?
Yes. Yeah. So there's lots. So a lot of it, the research comes from the pain data on people who use very low dose naltrexone, and anesthesiologists have known this for a while, at least in pain and with withdrawal, that if you give people very low doses of naltrexone, you can actually reset the opiate receptors or make conformational changes that make detox easier, that make actually increase your sensitivity to pain pathways. So that's a thing. I've never done it clinically. We do something that's kind of like low-dose naltrexone, which I'll show in a few slides, to get people from opiates to naltrexone, and I'll show you about that. And I have had patients, who are very pharmacologically savvy, who have bought naltrexone powder on the internet in a microgram scale, and then tried to microdose themselves to taper off of methadone. And one patient, and it did not go very well.
Yeah.
Yeah. So that's really fascinating stuff, and we should probably have a discussion later this year about that, because there's a whole literature there. And then people are saying low dose naltrexone works for everything, fibromyalgia, for all that, so there's a lot of interesting things. So anyway, so again, extended release naltrexone, 5 to 10% of patients, it might be useful, and these are the types of people that I've found it helpful for. I'm not going to read all these, but you guys can just take a look at them. And this is what a lot of the research is in, and when I kind of think about it. And really it boils down to, for a lot of people, any time that somebody's not currently physiologically dependent on opioids because they just got out of jail or residential, or they've been in the ICU for 2 weeks and nobody's been giving them opioids because they were delirious and alcohol withdrawal, those are potentially opportunities to start this medication. And you should at least be thinking about that when you're talking to patients. This is a protocol we don't have all the time to go through today, but this is a rapid induction protocol. This allows you to get somebody from opioids. Basically, they come in on whatever they're taking. They get 1 day of buprenorphine, and then you start microdosing naltrexone to build them up. And if they can tolerate by day 5 after buprenorphine 50 milligrams of naltrexone, then they can likely tolerate the shot, and then we give them the shot. The other thing we do is treat them very symptomatic opiate withdrawal during that time very aggressively. So one issue is people underdose clonidine, and then patients say it doesn't work. So it's very hard to bottom out people's blood pressure with clonidine during opiate withdrawal because they're so hyperadrenergic. So we give them 0.2 milligrams Q 4 to 6 hours, and just stop it if their diastolic drops below 60. And they can take up to 1.2 milligrams a day. And I've never had anybody have a bad outcome from it. It's one of the rare times in my practice that I use benzodiazepines. and I use clonazepam specifically because it doesn't test positive on urine drug screens, so it'll clear fast, and I'll know if they're using other benzos down the line, where if I give them Librium, at least at the VA, it'll be in their urine for 6 weeks, and I have no idea what's going on. So that's that protocol. Okay, I'm gonna go kind of faster because we have time constraints. So research updates, so no RCTs with all 3 together, no consistent predictions of response. Tapers, there's been about 28 trials now trying to think of any taper you could think of over any period of time. Can we get people off of these medications without high relapse rates? The answer is no. People always do better on maintenance. Relapse approaches 80 to 90% in 1 year for these patients. A lot of people cite this Cacao study from Lancet 2003, where they randomized people to buprenorphine, detox versus maintenance. At the end of the year, 80% were still in treatment for maintenance. Nobody was in treatment at the end of the year for buprenorphine, and like 20% was dead. So that's scary, and it's a good thing of why we keep people on these meds. One thing to mention about this study is each group was like 20 people, so people don't talk about that when they show the slide, but that it's concerning pilot data, I would say, maybe, or something. This is a great Cochrane meta-analysis that you guys should know about. It's 2014. It's about 30 trials looking at buprenorphine versus methadone. The big take-homes are methadone has much better retention. Has better retention than buprenorphine. And we know in addiction treatment, retention, the longer you're in treatment, the better you do, is associated with all sorts of things. So that's a definite strength of methadone compared to these other 2 medications. A definite weakness of methadone compared to these other medications is it's more dangerous. So methadone is disproportionately present in opiate overdoses. What that means, and some of this data is a few years old now, but it's still similar. So methadone is 3% of prescriptions in the US and 30% of the mortalities. Now, a lot of these are from pain clinics, not opiate treatment programs, but 50% of people who die from a methadone overdose do not have a prescription for it. So this is diversion from pain programs and from OTPs. And if you think about it, at OTPs, our methadone is particularly dangerous because I give somebody a shot glass with 200 milligrams in it, which anybody can take very quickly and also not really know what they're taking. If you want to take 200 milligrams of methadone, you've got to take 20 10 milligram pills, which is much harder to do. So that's something to think about. There's also these studies where they look, and just so you guys know, we're going to go over like 5 minutes or so, 10 minutes, but we'll have time for both. If that's okay, Pi. Yeah, okay, sure. There's also these population level studies, Britain, US, Germany, of everybody on buprenorphine versus methadone in those countries. And some of those countries, there's not as big of a difference as we have. There's no OTPs for methadone. You could get them both from your primary care. You could choose. And even with that, the death rate of people on methadone, controlling for all confounders that we can, is 3 to 6 times those on buprenorphine. So there is a mortality difference of being on these medications. So this is a summary of just that. If you're on them both and on a good dose, they both seem to eliminate opiate use in a similar manner. We have new data comparing buprenorphine to extended release naltrexone. There's a lot of people who have a lot of strong opinions about these studies. What I would say is the Norwegian study where they were randomized, it was bup at the window versus XR-Naltrexone in a shot. So it's a little different than the US, but they showed pretty much similar outcomes for retention and drug use. The US study was different. It was Vivitrol once a month like you always get, and it was also outpatient naltrexone. In the intention to treat, buprenorphine outperformed XR-Naltrexone in all ways, both opiate use and retention. And then when you do the data analysis, that was primarily, the majority of that was due to failures of getting people on Vivitrol. So either the person couldn't make it, or they got it and precipitated, they left, and they went and relapsed. When they did a secondary analysis of like people who actually successfully got one shot of Vivitrol, outcomes were identical to buprenorphine, pretty much. So that's what they said. Okay, so there's just like lots of areas of psychiatry, there's lots of questions still open. So you guys asked one of these, how long do we stay on these meds? We don't really know. I told you what I tell patients. One thing I think that's really important and isn't researched enough is like, when do we switch these meds? So there are people, when I inherited in my clinic who had been on methadone for 15 years and really are not doing well and had really made very little changes in that time. And so the question is, at what point is this medication not working, and how do we switch? When do we switch? Things like that. I think there's not enough research in that and not enough people doing that. But we've started, at least for newer patients, that whatever we put them on, we really look at the data, and within 6 months, if we're not seeing some signal of improvement, we start to thinking about switching the medications, because we have 3 options now. And in doing that, we've had some people have dramatically different responses in ways that we didn't predict. Like I've had somebody who'd been on methadone, done terribly for years, who went on to Vivitrol and did really well. And most people wouldn't think about that. So other things that are kind of exciting and new. So another big question is, like, there's a lot of argument in the field of like the DEX waiver. How much is it actually helpful versus a barrier? I tend to lean more towards the barrier side of things. For a lot of reasons. Fentanyl vaccine. So there's this idea of building vaccines to target different drugs. It's been primarily to try to do cocaine and meth so far, because we don't have meds, but the vaccines haven't worked yet really well. And they think, there was this presentation at AAAP last year from Tom Costin, who's like the big vaccine guy at Baylor, and he said there's something about the fentanyl molecule that he thinks he could build a really good vaccine for. So we'll see. And then the naltrexone implants that we talked about are coming. We're going to skip through these things because you guys know these. These are just clinical predictors of how we might think about treatment selection. And now I'm to my summary slides, which are when I try to think about treatment selection heuristics, so like rules at which how I try to decide who gets what medications. I think the 4 key factors that come up in my mind: patient preference, treatment history, or mostly lack of response, like we were just talking about, to something. Are they currently physiologically dependent? And really, and then also, what are their co-occurring, not only substance use, but psychiatric disorders? And in those 4, you usually can make your decision. It's usually pretty straightforward. Some other heuristics, like we talked about the patients before, new patient, no med preference, no treatment history. I would recommend considering buprenorphine first line for what we talked about. New patient with a preference, give them that preference unless you have some real reason for not doing it. If there's poor adherence, if there's continued opiate use, if they're not doing well, often it's switching, and often at this point it's switching to methadone. So there's a number of patients who you put on buprenorphine, no matter how high of the dose you give it to them, they continue to use and they're adherent. And some of those patients, when you switch them to methadone, from that partial agonist to that full agonist, it really stabilizes them, and it's helpful. And so that's most of the time when somebody's really failing, that's most of the time it's moving from buprenorphine, in my practice, to methadone, and sometimes they respond well to that. If they're not currently physiologically dependent on opiates, at least consider XR-Naltrexone. It's a thing you should just have in your mind as an opportunity that you may not have for some people for years, where they don't have opiates in their system. And the other thing I really encourage people who are going to do this work to is to either build a clinic or be in a clinic where you can provide all of these beds to the patients, so patients have the options that I think they deserve. And if you aren't able to do that in the system you're in, to at least be able to really have a good warm handoff to get them connected. And that is it. Here are my references. And are there any questions?
Yes. So buprenorphine being first line, when you're starting people on that, like how much, like you can't drive, period, when you're on buprenorphine, right? Like chronically?
Drive a car?
Yeah.
Oh, you can drive a car.
You can?
Yeah.
You definitely can.
Yeah.
Oh.
Like,
Somebody
yes.
told me you couldn't.
No,
That's
you
not
can.
true though.
Yeah,
Okay.
you can.
Well, that makes things better.
Yeah. I mean, when we start, sometimes people in the initial dose, they're in withdrawal, or then they might get sedated. Very rarely, like in more fragile people, I've had people get hypotensive. So if that's the case, then we're thoughtful about like getting you a Lyft ride home, getting a friend. But once you're on a stable dose of buprenorphine, you're totally fine. And most people on a stable dose of buprenorphine actually just say they feel normal, right? They don't feel medicated. You can't see any signs of sedation or ataxia or anything like that.
So it's just commercial driving. You can't.
Yeah. And it's really like DOT is you can't. And then with other like private businesses, it's variable depending on their policies.
Okay.
Yeah. Any other questions? All right, thank you for your attention.